I would like to introduce Dr. Chun Yuan for Martin Prince lecture, History of Future Direction of Vessel Wall Imaging. Please.
Yeah, thank you. This is when I was asked to give this talk, I started thinking about the history of this, and I think that even though vessel imaging has been started in the mid-90s, is the early days of the development, and it's still at this moment probably where the clinical application is of this field still remain to be a topic to be discussed. But there's a very long history involved in this. So my intention is to talk about the work that we have done over the years, and also many of the landmarks, I think that's in this field, to see where things were and then where we are now. And interestingly, when I was looking at myself, I realized that when I started my PhD work at University of Utah, my advisor was Dennis Parker, and many of you know that him really well. He really is the one that brings me into this vascular imaging field. So since then we have actually done a lot together, and also the other part of this is the vascular imaging lab at University of Washington. That it's where a lot of the work that I will include in this talk. So if you were to look at this field of so-called vascular imaging to see where things are, if you just do a literature search of the PubMed, this is what you can get. You can actually see this progressively increased interest in this field and also publications. And where this really, in contrast to the so-called regular vascular imaging, especially angiographic-based imaging, is really the question of what are we missing from angiographic images? And in particular, an example like this showing a very nice picture of a carotid stenosis. But what is really missing of this information really is the so-called, what is behind the stenosis, whether that actually matters. So now back into the 90s, I think that when we started looking into vascular imaging in MRI, this were probably the main questions people were interested. If you look at this from a vascular surgeon's point of view, the question really is how do you, if you do carotid endarterectomy, in terms of prevention, and even for this reference, it is from 2010, is that you need the number of patients who need to be treated or going through surgery in order to prevent stroke in this population, in this asymptomatic and stenotic carotid population, is highly questionable because it's not perceived to be efficient. And the second big question at that time is really from a cardiology field, is the belief that, is it really true that most of acute coronary symptoms really arises from rupture of mild stenotic plaques? And whether this type of mild stenotic plaques really are the ones that lead into more adverse events. And if you were to look at these two questions, what they're really both focusing on is what information stenosis is providing, whether that actually is adequate to describe the disease, and whether you can use it to predict the future of patients' outcome. And another area of this is that if you look back into this vascular field, is that statins or cholesterol-lowering treatment started to become available also in the field in the 90s. And then the question from that time on also is, what really is the impact of statin treatment in terms of atherosclerosis itself? So those sort of drives the question of why we want to do vascular imaging. And then, but if you go back to that time to think about how this can be done, I think this so-called vascular imaging is comparing to a stenotic angiographic imaging or the improvement of technology. There's fundamental thing missing is we don't even know what we are supposed to be looking at. And if we were to look at atherosclerosis, what is the composition of what aspect of atherosclerosis is supposed to be imaged? And then the next thing is is what techniques are you supposed to use to do this? And how do you actually validate those techniques? And the last one is, which vascular bed can you actually do this with? So when I started at the University of Washington, I was lucky enough to actually to work with this Dr. Eugene Stranis. He was a vascular surgeon. He had a SCORE grant as listed here. The SCORE grant was probably the first one trying to use so-called imaging to image atherosclerosis, but the program itself was entirely ultrasound-based. And that was the beginning point of MR's involvement with vessel wall imaging. And when I started there, I was also lucky to have two collaborators. One is Dr. Tom Hazukami, that he was a vascular surgeon. He started using this so-called surgical procedures, removing plaques intact, where you can actually, you will not destroy the so-called surface of a plaque. And when you evaluate that with histology, you can actually get reasonable 3D pictures of it. And the other person we have was Marina Ferguson, who was a pathologist at University of Washington, who really helped to develop the so-called stainings and looking at composition of those specimens for us. And then from there, we started to look into this, whether we can do in vivo imaging before patients who are scheduled to have carotid endarterectomy, and then have those to establish this entire train of validations of what imaging can do, and then what we can see with histology, and whether we can actually create some sort of validation of the picture there. But then if you look at this picture, these are the images, MR images. These are the early days of MR images of a carotid. And you immediately can tell there are a number of technical issues you're dealing with. One is the signal to noise is clearly not good enough. The second thing is, if you want to look at vessel wall, you really have to have very good flow suppression. And then in addition to this is that what specific type of imaging you can really use to bring out the so-called tissue contrast you can see in atherosclerosis. So this also in the early days, that I was lucky enough to have Dr. Cecil Hayes at University of Washington, and he introduced this idea of using phased array coils to do carotid imaging. So this was the very early picture of a carotid phased array coil, including the hat holders and this. And this was actually published in, I think it's 1996. And these are the very early images taken from that time with that carotid coil. You can see that the impact of this coil is actually tremendous. In fact, in terms of bringing in strong enough signal noise, so you can really play the so-called spatial resolution game in this. And this was one of the early papers we had, was 97, that basically showed this so-called in vivo imaging and then with histology, and how do they correlate and so on. So that was, it's one of the very early publications in this. And then in the meantime, at University of Washington, we were able to work with a pioneer in vascular biology field, that his name is Russell Ross, that he was interested in this animal models and looking into atherosclerosis progression. So we used a rabbit model imaging and basically demonstrated that you can actually see this so-called by serial imaging of the rabbit aorta, you're able to actually see progression of lesions. And then it's strongly correlated with histology. So this work was actually published in the first issue of Nature Medicine. And it was recognized as a landmark work because now people can start visualizing atherosclerosis and its composition with imaging. And before this was considered was not possible. In the meantime, there is another pioneer in this field, is Dr. Valentin Fuster, that he's at that time, when this was first published, he was actually at Harvard, and then he went back to Mount Sinai Medical Center in New York. And this is the publication they had, highlighting also in carotids, and using T2-weighted imaging, you can actually visualize this lipid-rich necrotic core. So from there, there's a series of work that actually gets published. And this is one of the, in 2001, and it's so-called multi-contrast for vessel wall imaging, and it's a publication in circulation. This is a picture that we included in that, looking at so-called intraplaque hemorrhage, and also looking at loose matrix and other tissues of plaques. In addition, in this paper, that we started introducing not only including multi-contrast, but also with the so-called what contrast it may actually be used in each type of tissues. And in that same paper, that was, I think this was the first time we started really looking into this thing of intraplaque hemorrhage. This is the so-called bright signals on T1. And then if you look at this, what is really striking of this is this plaque, the entire plaque bulk contains mainly intraplaque hemorrhage. That is, before this, probably the people really did not pay much attention to the presence of this so-called intraplaque hemorrhage and whether it has any impact in terms of risk. But this was a very early example of what this actually looks like. And you can tell by anybody when they look at this, it's easy for people to appreciate. This type of plaque with a pool of blood inside is highly unstable because you can actually, any kind of a mechanical force in any means may actually rupture it. And then from there, that we started another work we did, and this is done by Jianming Cai, who was a fellow in our lab at the time, and was looking into whether we can use AHA's lesion definition translated into an MRI-based definition of lesion types. So this was another paper we published early in circulation, looking into defining lesions based on MRI, but with a so-called histological validated lesion type definition. And from there, another interesting work of this is the so-called use of contrast. And we published a paper in 2002 in this. And this was basically showing if you use a regular gadolinium contrast and inject into plaques, what changes can you see? Actually, we see that it's quite interesting, and what we're also concluding is by doing this, you can see this so-called lipid-rich necrotic core as a non-enhancing region very well. And this work also is done it's almost at the same time by Dr. Bruce Rosserman at Johns Hopkins, and also showing very similar effect of using contrast into carotid arteries. So this is the beginning point of contrast agent use in vessel wall imaging, is its value for looking at fibrous cap, and also its value for looking at lipid-rich necrotic core. And then another aspect of this work was introduced is by Bill Kerwin, that's also from the vascular imaging lab, is if you're able to actually acquire this dynamic contrast information at the time of contrast injection of the plaque itself, you can actually estimate the so-called K-trans and also VPs as two traditional measurements from dynamic contrast. And what he is able to show is there's a strong correlation of K-trans versus macrophages, and also there's a strong correlation of VP versus the so-called blood, the concentration of contrast agents at certain areas. So both of these are very good measures. One is on new vessels, and the other one is on so-called plaque inflammation. And this essentially leads into this MR contrast application into not only looking at plaque composition, but looking into plaque inflammation. And another interesting work, also by a pioneer in this field, is done by Elena Kui from University of Maastricht. And this work looking into using USPIO type contrast agents and also targeting macrophages in atherosclerosis. And this particular study demonstrated is you can truly see there is uptake because of this. The challenge of that has been that this is a negative contrast agent, therefore that you see a signal reduction over time where there is uptake. And during this course of this evaluation and so on, there is also a series of so-called imaging parameters or measurement parameters that were introduced. Because of, if you're able to measure vessel wall, especially vessel wall may actually grow outwards. It's not necessarily just maintained as a stable state. So if you were to do this measurement, one important aspect was introduced was this so-called normalized weight index. Is trying to adjust the changes of lumen area and also adjust the change of vessel wall areas into one parameter. And it's basically just simply it's a estimate based on wall areas and outer wall areas. It's called normalized weight index. So there are many so-called plaque burden measurements started using that type of parameter. And also with Bill Kervin at our lab that we developed this software called Cascade. The intention is that you can actually integrate multi-contrast data for quantitative measurements of the areas and also its composition. And this was actually introduced in the mid-2000, around 2005 and 6. And at that time, this so-called AI is way beyond that. It's premature, really. But we introduced an algorithm. It's a semi-automatic algorithm to really do tissue characterization. And it turns out to be quite effective until AI, a new so-called network-based approach, becomes more useful. And then the next question is that you can see all these tissues, so what? Whether this actually provides any data, any useful information. So this is a early paper that we published looking into so-called identification of fibrous cap rupture and its relationship to events, stroke or TIAs. Basically shows that the cap rupture identified on MR images seems to be very indicative of risk of stroke or TIAs. And then another work, and this is by Dr. Alan Moody, who at the time was at Nottingham and then moved to Toronto. And they published a paper in Circulation. At the time, they called this direct thrombus imaging. And basically, it's the so-called bright signals on T1 weighted imaging. This essentially translates into the intraplaque hemorrhage we have actually observed before, and with also those matching histology. Essentially, we sort of moved into the same direction. And in this paper, his group basically argues, if you see this so-called high signals on T1 weighted imaging, this probably is a high-risk plaque. And there are evidence there's strongly associated with TIAs and stroke. And another work, the early work in this field was done by Norihide Takaya, who was a fellow in our lab at the time, that is looking into whether that any of these features we see in carotids that actually related to subsequent clinical events. In other words, in a prospective setting to see where things are. And what he demonstrated, there were two key factors here. And one is the so-called, whether patients have IPH or without IPH in plaques. You can see there's a clear evidence of worse outcome if you have intraplaque hemorrhage. And the other one is, again, is the thin or ruptured fibrous cap, and as another indicator. So this is started to migrating into, in addition, MRI is able to characterize lesions, but also MRI in this case is able to identify what of these features may actually be high risk. And another work is done actually by, this is, sorry, the label is wrong. It's not Cordy's picture. This is, you probably all know him. That is Zahi Fayyad, that he is actually leading a big group at Mount Sinai doing also vessel imaging. And this is the other area of vessel imaging's role is they had a very early publication demonstrating statin's effect of vessel wall itself, demonstrating that you can actually see there's a reduction of the vessel wall area in aorta in other vascular beds. And this was they published it this was, I think it's, which year was this? It's 2000, I think it's also 2000. And another work is done in Seattle in collaboration with Dr. Xueqiao Zhao. That she's a cardiologist, and we did a study looking into so-called long-term effects of statins on carotid plaques. And what basically showed is you see a compositional change from lipid ridge into fibrous tissue ridge. And the other one is you actually see an increase of calcium because of statins treatment. So this actually has been confirmed later on by many studies, is the lipid depletion aspect of this, and also the aspect of may actually introduce calcium. Another work, and this is the question of if you have information of plaque burden and lesions, and also you have stenosis measurement, and whether this leads into a question of whether there are lesions out there without stenosis. So Li Dong, that she was a fellow in our lab at the time, did a study looking into this so-called the contralateral side of carotid patients who already have advanced lesion on one side, and looking at the other side. Basically what this demonstrated is there's a significant chunk of patients who already have advanced lesions on the other side, but they don't have severe stenosis, meaning this information is adding to the value of what vessel wall imaging is doing. And as I will talk a little bit more later on, is also providing a challenge in that area. And another work in this is done by Tobias Sam, that he was a fellow in our lab also in 2000, looking into this so-called, suppose you divide lesions based on stenosis and also based on high-risk features. How do they distribute? And this basically demonstrates they are still high-risk features, even the stenosis level is near zero by a clinical measurement. So also in 2000, there is a landmark paper published by the lead author is Monteza Nagavi, that this is the famous one that was histological definition of so-called vulnerable plaques and based on coronary arteries. And as you can see that this field, how this field actually developed, there's an intersection of what MRI imaging is going, where histology is going, or the field, the cardiology field is going in it. So we, with many labs work in this vessel imaging field, essentially come to an agreement of in carotids, these are the so-called high-risk features, and including a large lipid-rich necrotic core, or intraplaque hemorrhage, and also fibrous cap rupture. And then there's a particular phenomenon of carotids that I think is worth mentioning, is this a so-called intraplaque hemorrhage, because intraplaque hemorrhage is not considered as a major composition of coronary plaques, but is a major composition of carotid plaques. And its risk is this early papers already suggesting its risk. And this actually has been demonstrated by many different type of studies. And if you look at the publication in this, actually there's this, after the validation of MRs, you see this very significant work getting published by many different groups focusing on looking at intraplaque hemorrhage. And a major one, I would say that in recent days, there are many meta-analyses of this summaries of different studies in this. This is the most recent I can see is from 2020, and it's by Dr. Schindler in Munich. And his summary, I think, probably can be summarized, this underlying statement is, intraplaque hemorrhage is common in patients with symptomatic and asymptomatic carotid stenosis, and is a stronger predictor of stroke than any known clinical risk factors. And I would like to add another statement here is, MRI is probably the only effective imaging tool to identify this. This, for ultrasound and for CT, being able to identify this, the capability remain to be weak. And another aspect of this, I think this is a publication by Jackson who also works at vascular imaging lab in Seattle that is looking into this so-called time course changes of intraplaque hemorrhage. Because logically, if you know intraplaque hemorrhage is a risk factor of leading into clinical events, then the very next question is whether you can actually predict who actually is likely going to progress, whether we can identify those. And I must say that this remains to be an interesting aspect, and at this moment, we still don't have a solid answer one way or the other. But this study seems to be suggesting not only you can see this progression over time, but also if you were to measure the signal intensities of this, there is a signal intensity change within this so-called intraplaque hemorrhage region. We don't know what's the cause of it, and we also do not know whether this is an indicator of rapid progression. And another aspect of this I mentioned very little is when you started looking into this field of atherosclerosis, there is a big difference of, for example, in East Asia, including Japan, China, and Korea for that matter, the rate of stroke is higher than heart attack than Western countries. So if now that we started to have this understanding of what we can visualize atherosclerosis, whether we can actually use this as a tool to understand what are the major differences, why there are these differences in different ethnic groups. So this is a study that done with the two PIs are Xihai Zhao and also Rui Li from Tsinghua, is looking into in a Chinese population, and if they all had stroke, how many of them actually have carotid lesions? And it takes a long time to summarize it, but I would just briefly summarize the key information of this. I think it's quite interesting is, these are all the so-called stroke subjects after you eliminate people who are from hemorrhagic stroke, who are likely from the source from the heart, let's say, taking all these people out. The rest of the people are falling into this category. And then of them, this is group 1, 2, 3, 4, all people who have carotid lesions. Okay. And then if you were to divide this group into lesions with larger than 50% stenosis versus less than 50% stenosis, you see a distribution of this. And this basically will be, if you use stenosis as a criteria to determine where the patients are, these are people probably 143 arteries are with carotid lesion with a severe stenosis. And the others, majority of them have less stenosis there. And then if you define this based on high resolution, high risk plaque, meaning whether they have intraplaque hemorrhage, surface disruption, or large leprosion of aquatic core, that this is the group that fit in. Group 1 is high risk and high stenosis. Group 2 with a severe stenosis, but with no clear high risk plaque features. And there's a group 3 is most interesting, is with high risk plaque, but with no stenosis. So this leads into the question of cryptogenic stroke, because of these people, based on the current standard of diagnosis, probably will be labeled as somebody who had a stroke, but the source is not likely to be carotid because there's no severe stenosis. So the issue of cryptogenic stroke and whether vascular imaging should actually play a key role in its evaluation started to come out because of studies like this.
Jim, could you wrap up?
Yeah, okay. And then the next one is from Dr. Anna Kupasek, and this is actually done in its perspective study, particularly looking into this so-called ESUS patients, and whether that among them, there are patients who have evidence of advanced carotid lesions, but without severe stenosis. And this is the group, basically, and showed where they are. And there is a clear group may actually be underdiagnosed because of their stenosis level is not significant. I will quickly to summarize that since then, if you were to look at this field from the 90s to now, that in addition to carotids, vessel imaging now has been expanded into many different territories, especially in intracranial arteries. There are a lot of people are engaged in that work, and also there are a lot of very interesting studies done in that. But I'd like to actually point to something that is quite interesting. Is this is a sample of coronary artery, so-called vulnerable plaque. It's called thin-capped fibroarterioma. Okay, and the truth is, you don't see this type of lesion in carotids that often at all. And so the question really is how do we actually, of lesions going through different vascular beds, that whether that there are ways we can differentiate them, and also understanding how they actually, the risk of progression and leading to clinical events, whether they actually mean the same thing for different vascular beds. And also, this is a question for intracranial artery there also. And I like to use a meta-analysis of intracranial results to highlight this point. This is done by Jie Song, who's at UPenn. And she's concluding that based on all these published studies in intracranial artery, in addition to so-called positive remodeling and also cap rupture, those type of features, is contrast enhancement is a risk factor. And the question really is, why a lesion in intracranial artery enhances, and what is the composition of that with this enhancement? I think this information is missing. We need real histological validation to show what it is, because all the current information of so-called lesion composition and changes is based on carotid atherosclerosis imaging. And for other vascular beds, I think the composition may actually be different. And what it actually translates into, I think that we actually need real physiological validation to find the answer to. And I think the other thing that is very interesting is there are action groups now, and this is from the American Society of Neuroradiology, in terms of intracranial atherosclerosis imaging, and also in terms of carotid artery atherosclerosis imaging, that what this type of imaging can do. So they're starting to have white papers coming out trying to introduce different aspects of this. And I'd like to just finish by using this example. And this is just published several days ago. And it's an intention of generating a so-called scores based on carotid atherosclerosis. So can be shared with different modality, and also can be shared between radiology people and also neurology and neurosurgeons. So as such that the hope is this may help to bring the language together and the risk factor assessment together. So in summary, I think that this has been a field that has gone a long way from the beginning of not knowing what to image to the point of we have pretty good understanding of where things are. And also, but I think that there's still a lot of challenges. For example, in carotids, not only we're facing challenges for clinical adaptation, but we also are dealing with how do we actually deal with intraplaque hemorrhage, knowing it has high risk, and knowing that we don't have a very good way to predict whether it will lead into fast progression or regression, and we need more studies in that area. For intracranial artery, I believe we truly need to have better understanding of what we're imaging, because its enhancement now is being interpreted either as inflammation, an active plaque. If you really ask the question of what are we imaging there with this enhancement, I think the histological validation of that is fundamentally missing. I hope that somebody will be able to do that. And the other aspect of this, I think it's very interesting, but it's hard to study, is the aspect of non-stenotic lesions. This has now been recognized in both carotids and intracranial arteries. It has been the driving force for coronary arteries. The question is, how do you find them? And also, if you were to find them, that you visualize these lesions and they have some sort of high-risk features, what to do with it? Because clinical guidelines have not addressed that issue much at all. So with that, I'd like to summarize and also acknowledge the vascular imaging lab. And this is one of the, this picture was taken 2019 before the COVID. And then we have actually gotten a significant amount of grant funding from, especially from the NIH over the years. Thank you.
Thank you.